Good morning. For those of you who are watching by live stream or will watch a recording of this in the future, I am Terry Roselle from the Division of Bioethics here at Kansas City University, and by way of the Center for Practical Bioethics downtown Kansas City. And I am introducing our third lecturer in the series we call Current Issues in Bioethics. Dr. Lizzie Reis comes to us today from City University of New York, where she teaches courses on transgender issues, reproductive technologies, the politics of women's health, medical ethics, bioethics, and the history of medicine. She has written and edited books in these fields of study as well, with interesting titles like An American History of Intersex, Sinners and Witches in Puritan New England, and American Sexual Histories. Dr. Reis is a historian by training, and like Dr. Randolph on our faculty, she has focused primarily on historical studies of medicine, specifically human bodies and health, and particularly sexuality and gender. Today, Dr. Reis will talk to us about the ethical care of transgender and intersex patients. So, do you need to know about this so as to prepare for questions on board exams? Maybe. This is increasingly an issue of interest and concern in the wider community. And if we're not testing you on some knowledge and skill level relative to treating intersex and transgender patients, the exam preparers are not doing well. So I would think this is good preparation for board exams. Beyond that, you'll also want to know some of the things that you learned today for better care of transgender and intersex patients who will come to you in your future career vocation as physicians. So please welcome today Dr. Lizzie Reis.
Okay, is this a good volume for people? If I start to get, usually I have spoken in a large lecture hall like this without a microphone, so I'm used to kind of really booming my voice, and so if that starts to happen and you're, just raise your hand and say I'm way too loud, and then I'll modify. So thank you so much to Deb Mitchell and Terry Roselle and John Carney and the rest of the people here for asking me to present on trans and intersex issues. I've been teaching this material since actually 1998. And at the time when I first started my first class on transgender issues at University of Oregon, I don't think there was a single student in the class who knew what it was, but they either liked the time that the course was being offered at, or they had taken another class with me and they knew that they could get a good grade. But now when I teach it, every single student knows at least they know what transgender means. They might not know about intersex, but they'll come to learn that, as you will today. Or they're trans themselves, or they're dating somebody who's trans, or they have dated someone who's trans, or they watch something on TV. They have a passing familiarity. And let me just also say that I know that when I talk about this, there's a range of how much you all know on this topic. And so I know that there's some people who might be trans here and who really, they're living this, and so they have a firm understanding of everything that I'm going to say. And then there's other people who might be thinking, I never really heard of this. And that's fine too. So I'm just going to try to pitch this somewhere that will satisfy a lot of people, and hopefully you'll learn something from whatever I'm saying. So I'll start by saying in addition to the things that Terry just said about me, I'm also on when I lived in Eugene, Oregon for 27 years and taught at the University of Oregon, and I was on an ethics committee at the hospital there. And now that I moved to New York 3 years ago and teach at CUNY, I'm on the ethics committee at New York Presbyterian Weill Cornell. And sometimes trans issues come up in that context. When I was in Eugene, the hospital wasn't big enough to do any gender confirmation surgeries. It just wasn't that big of a hospital. And it was also a Catholic hospital, so they weren't going to do that anyway. But nonetheless, issues still came up to our ethics committee having to do with transgender patients. And so this is something that, even though this might not be on your board exams, I hope that you do listen to this, even though it's not going to be on the test, because I guarantee you, with the way that the acceptance of transgender people is happening in our society, this will come up for you at some point in some way. So I'll just, I want to kind of give the background is that transgender patients face a lot of barriers to quality health care. And this includes people who just don't know that much about transgender care. That's, kind of a general ignorance is kind of one thing. And then there's another layer to this, which is a pretty alarming amount of transphobia in the healthcare world. And it's not just limited to the healthcare world. I mean, there's an alarming transphobia in the world more generally. So this is something that, when it comes up in a healthcare context, this is something that you all can change, as you go through your program and become physicians. And even the most sensitive hospital or office staff may have to confront unique questions regarding the ethical care for people with gender variant bodies or gender variant medical histories. So hospitals and medical practitioners, for instance, can make a more welcoming environment for patients by adopting more inclusive intake procedures, by asking about gender identity, by conducting a physical exam in a way that's comfortable for the patients. And that's some of what I'm going to be talking to you about today. So one case that we had that came up, and I've changed some things here, obviously, for confidentiality, but you get the drift of the kinds of conversation that we had about this. We had a patient, female to male. So this is, sometimes you'll see the initials FTM, which stands for female to male. He came into the hospital. He wanted to go by his male name. He had a male name now. I'm going to make it up that it was Aiden. He wanted that name on his medical record. He wanted the hospital staff to use his male pronouns when referring to him. And he didn't want anyone to mention his female past. Now, some of these things were totally easy. Pronouns and the names, everybody was, on board with that and, just ready to do that. But the last request was a little bit tricky, and this was something we discussed in our ethics meeting. Was it reasonable not to make any notation about his female past on the chart? So when you're charting, do you say anything about this? He considered himself a male. He lived as a man. He had had chest surgery. So his chest looked like a typically male chest. He was taking testosterone, but that wasn't what brought him to the hospital. He was there for gallbladder surgery. It didn't involve his transgender identity, and he didn't want that information about his transgender status to go on his record. Eugene is not that big of a place, and people talk, even though they're supposed to be, they're supposed to maintain a certain level of confidentiality about patients that come into the hospital, but he was sensitive about this and didn't think that that would happen. So after a lot of discussion and learning, because a lot of people on the ethics committee didn't know anything about transgender issues, our committee recommended that only the medical information necessary to take proper care of him would need to go on the chart. So we didn't need to say that he was trans or that he had had a female past, but they were going to say that he was taking testosterone. But we could kind of leave it, other men take testosterone too, so it wasn't so critical. And Aiden agreed to this strategy of keeping an open discussion of his transgender status to a minimum, but letting his physicians and nurses have all the relevant medical information. And our group kind of came to the conclusion that it would be more important for his primary care physician to know his full medical history, which included his typically female anatomy. He didn't have bottom surgery, which I'm going to talk about that in a second. So this is especially important for trans men who still have their breasts, and some do. they can still get breast cancer. They still need to get mammograms. This legacy of a female past can be awkward for a female-to-male transgender patient and really needs to be approached in a manner that illustrates that it's being done for the patient's best interest and not as a means to return to a prior gender identity that was painful and incompatible with the sense of who they are. So instead, it needs to be cast as part of their current health needs, part of supporting their well-being. So for men like Aiden who haven't had any bottom surgery, and that's the majority of trans men, routine pap smears should not go by the wayside. He still needs, even though he's a man, he still needs to have a pap smear. Testosterone can actually cause thinning of the walls of the vagina, and that can increase the risks of sexually transmitted diseases if the person still uses their vagina for penetrative sex. Sorry, I know this might be like TMI, but you're all going to be doctors, so you can handle this. But not all trans men do, but if they did, then you would want to make sure that the testosterone, that you were getting things checked out. Unless Aiden had his ovaries, uterus, and cervix removed, he would need regular pelvic exams and regular cervical cancer screenings. So the goal for him would be to feel comfortable enough to go to his primary healthcare doctor for routine healthcare needs. Now, just recently, I went for an annual mammogram, and as I sat in the waiting room with many women, there was also a trans man in there who still had breasts and who was getting a mammogram. And this wasn't the place that I went to, but I just found this on the internet as kind of typical of the place that I went to. I just felt like this was pink, 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 pink. Oh my God, is this really necessary? I mean, why can't we just, you could tell that this guy felt uncomfortable there in a waiting room with all women, and you're barely covered because those gowns that they give you don't really cover you, and you're sitting there waiting for the next, ultrasound or whatever. And this guy was sitting there in this very pink and gendered space, and I just thought, this could be different. It could just be like you're going to get, I don't know, your urine tested or something. It's not such a gendered space for that. Is this really necessary? So medical spaces could be made comfortable for all patients. But if Aiden and other transgender patients feel shame and judgment when they go to the doctor, then studies have shown that they're just much more likely to go at all for routine care. They're just much less likely to go through that. According to the 2011 National Center for Transgender Equality National Gay and Lesbian Task Force report, that's what this is, of the 6,456 trans and gender nonconforming people polled, 19% had been refused medical care, 28% had experienced verbal harassment in a medical setting, and 2% had been physically assaulted in the doctor's office, which is, it's all alarming, but that really, this is another chart that shows the breakdown of refusal of care by gender identity. So the total is on the left, 19%, male to female is the second bar, then female to male is the third bar, and then finally on the right, gender nonconforming. 50% of respondents reported having to teach their physicians how to care for them. And so I'm hoping that, here I am doing a talk like this. Physicians who are older now didn't have this kind of education, so by the time you all are seeing patients, if somebody comes in and they're gender nonconforming or they identify as trans, you'll be like, oh yeah, I know what this is. This isn't a problem. Here's a few quotes from this report. One person said, after an accident on ice, I was left untreated in the ER for 2 hours when they found my breasts under my bra while I dressed outwardly as male. Another person said, I've been refused emergency room treatment even when delivered to the hospital by ambulance with numerous broken bones and wounds. So, talk about the unethical care. That's what this shows to me. There's a philosopher at Southern Illinois University at Edwardsville who's been writing about the unethical care of trans patients. And she makes the case that Well, she says, is the refusal to treat trans patients, can we consider this like conscientious objection, kind of a form of conscientious objection? If you don't agree with this, then it's okay. If you don't agree with a person transitioning, then it's okay. And she argues that no, that it's actually it's a betrayal of the patient-provider relationship. Because particularly when the patient is supposed to be receiving care that has nothing to do with their transgender status. They come in with a broken whatever, and they're not asking to be, to have gender-conforming surgery when they come in with a broken arm. They're just asking to be treated for their broken arm. And she argues that even if the provider objects to providing services for what they consider immoral, if they don't agree with it, let's say providing prescriptions for cross-gender hormones, she argues, and I agree, that it presents an undue burden to the patient to refer them to someplace else, particularly in areas where there is no other place, and just contributes to a negative climate. It limits the trans patient's access to health care, it damages their well-being, and reduces the chances, as I mentioned before, that they'll seek health care elsewhere. All right, I had another case, but I'm going to leave that one aside because I have too much to go over. Well, I'll just tell you what it was about. Another case had to do with where there was a psychiatric ward in the hospital that is divided by male and female. And there was a person who said that she was a woman and was supposed to be in the female side. She wanted to be in the female side. But she had been born male, and she was very aggressive, and people on the female side didn't like her. And she hadn't done anything medically to effectuate her transition. And so the women on the female side said, we don't want her here. She's not even really a woman. And so then this came before the ethics board, the ethics committee too. Like, how do you decide who is a woman? Is taking estrogen enough? Do you have to have breasts? Do you have to have had what used to be called sex reassignment surgery and now is called gender confirmation surgery? Do you have to jump through all those hoops? Well, for a person who's homeless and has many psychiatric issues, getting all those things is pretty much impossible. I mean, she's probably never going to have any kind of medical transition. But she had been living as a woman for, 25 years by the time she got to this point. So to put her on the male side seemed wrong. And we didn't. What they ended up doing was have her, they just dealt with the behavioral issues separately and said, you cannot have this kind of bad behavior. I can't remember what she was doing, but they signed a contract about having good behavior, and basically like that's what you need to do to be a patient here in this unit altogether. And she was able to stay on the female side, and things kind of settled down a little. The U.S. Department of Housing and Urban Development has actually published guidelines for homeless shelters in 2015, and they explicitly state that people who are trans should be assigned to, when they're assigned to single-sex shelters, should be assigned to the ones that conform with their current gender identity, and that anything, what they've done to their body or not done to their body, doesn't matter. And we agreed that even though she hadn't medically transitioned or actually legally transitioned either, in terms of like her driver's license, well, I don't even know if she had a driver's license, putting her in with the men would have brought on more problems than it solved, and her abusive behavior might have even gotten worse, and because she would have been living in an environment that she didn't feel comfortable. So basically, there are several things that healthcare providers can do. They can treat transgender patients with the same dignity and respect that they would treat any other patient. I mean, and this is just kind of like a basic take-home, take-away message. If you remember nothing else, if you remember that, that's a good thing to remember. And the nature of a doctor's visit really necessitates like an intimacy. I mean, probably some of you have been to the doctor, and you know that that interaction necessitates an intimacy that a lot of trans patients fear because of the kind of reaction that they sometimes get. But with care and sensitivity, a relationship can evolve that will encourage trans people to continue with routine medical care, which will ultimately lead to better health outcomes. Another thing, so treating with respect is a main thing. And also, trans physicians should understand that the bodies of many trans patients might look different than what they're expecting. And instead of, recoiling in horror, you have to, put on your doctor hat and realize that, for instance, trans men may have had chest surgery, so they no longer have breasts. But if they haven't had bottom surgery, they will still have a vulva and vagina. But if they've been taking testosterone for a long period of time, their clitoris might look larger than the average natal woman's clitoris. A person at the beginning of their transition with only a few months of hormone injections, they might still look typically female, even though they identify as male and use male pronouns and a male name possibly. So, a person undresses and you're looking at their body, you have to just kind of be attentive to the body that's in front of you and not have other expectations and just deal with, if they have these parts, we're going to do this. If they have these parts, we're going to do that. Similarly, a trans woman, so somebody who is going from being a natal male to living as a woman, might be taking estrogen and so has developed breasts, but may still have a penis and testicles. So there is possibly going to be an incongruity there. And physicians, I think, will do right by their transgender patients if they embrace difference and heed the recently coined phrase of some intersex activists, and I'm going to talk about intersex in a minute. The expression is, no body is shameful. And I think I like to just keep that in mind, and I think that, you all, emerging physicians, if you have that in your mind, and nurses and everybody else in the healthcare world, if people just think this, it's not even just for trans and intersex patients. I mean, people who are considered obese kind of confront some of the same body shaming that happens when they go to the doctor. So it's just, this is a problem, and people with various disabilities. I mean, this is kind of an issue more generally. No body is shameful. If we all kind of held that at the forefront of our minds, I think we would be better off. Another thing, not only do physicians, they should take various bodily shapes in stride, various conformations in stride, but they should also not assume that all transgender people are planning to undergo a complete transition. Some people do some things, they don't do others. Some people want hormones and they want to have surgery. Some people don't want to have surgery. For some people, they might want to, but it's hugely expensive, so it's just not in the cards for them. Some people would rather spend their money on facial feminization surgery. And there's some male to female trans people who might not really care about what's under their clothes because most people aren't seeing that. But when they're dealing with people face to face, they want their face to look more feminine. So might have, various kinds of plastic surgery to effectuate that. So as I said, sensitive physicians can just take care of the body that's in front of them, advising the patient accordingly. If a female to male patient has breasts, they can emphasize the importance of breast exams. If a male to female patient has testicles, they can talk about the warning signs of testicular cancer. And we really shouldn't assume a seamless trajectory of these surgical procedures in order to be gender conforming, because that's just not how the world really is. Okay, we already did this. Yeah, see, I forget to go through my slides. Okay. One thing that physicians can do is stay well informed about transgender cultural competence and healthcare standards. There are some standards of care that go through WPATH, which stands for the World Professional Association for Transgender Health. They're contentious. because they're constantly in an evolving state as well, but a new version of them is coming out soon, so that can be something to look for. And a lot of hospitals these days, this is just one example, have transgender affirming hospital policies. And this is all very new, but a lot of hospitals are doing this now. So this is one from the Mayo Clinic. It says being transgender indicates diversity and not pathology. And so I've done a lot of work on transgender history, and this is all just really new, because the way that trans issues used to be talked about was as a mental illness, a pathology, and this is in the process of evolving. So you have something like this, the Center of Excellence for Transgender Health, the Fenway Institute in Boston. I don't expect anybody to read the slide. I'm just basically showing that the Fenway Institute has this too. Many of these places are very friendly to lesbian, gay, bisexual, and transgender people and their healthcare needs. And that is a good segue into talking about intersex, which is often left out of this, including this. And I'm going to talk about intersex. I'm going to turn to that now. Intersex and transgender are not the same, although there is some overlap. Oh, wait, there's one more slide, 10 tips from the Mayo Clinic. Whatever, you can just look these up on your own. Here's another one. Okay. Intersex is not the same as transgender, though there are some overlapping issues and some overlapping people. What is intersex? It's atypical sex development. It's an incongruence between genitals, chromosomes, reproductive anatomy, and hormones. You might know of it as DSD in the medical context, disorders of sex development. And intersex is not always apparent at birth, which I'm going to talk about that more in a second. But so just from here, this is something that happens at birth. So this is how it's different than transgender identity, because that is something that a person comes to feel as they get older, that they don't feel the gender that they were assigned at birth. If you have an intersex baby or a baby with intersex traits, often there's ambiguous genitals. So right away, the baby's born and everybody's saying boy or girl, and you can't tell immediately. It's called DSD in the medical arena. And the reason why this is contentious as a label is that people who are intersex don't feel themselves to have a disorder. They just feel like it is part of life's variations. Some babies are born one way that look typically male, some are born typically female, others have ambiguous genitalia, and to call it a disorder leads to an automatic fixing of it. And I'm putting fixing in air quotes because as I'll come to say, that the intersex condition doesn't really go away. It's cosmetically fixed, which leads to some bad consequences. But nonetheless, in the medical arena, it is called DSD. Some people would rather call it differences of sex development or divergence of sex development to make it a little bit less pathologizing. But doctors still do call it DSD. But that's way better than the old-fashioned term, which was hermaphrodite. And everybody agrees that using hermaphrodite or hermaphroditism is bad because it kind of conjures this idea of a mythical creature. And I think I forgot to put the slide in there. Yeah, I don't have a slide of the mythical creature. I should put that in for next time. But it's a 16th century woodcut of this one-legged winged monster. And that's what they thought a hermaphrodite looked like. So obviously no intersex people look like that. But some babies are born exhibiting some combination of male and female genitalia, a clitoris that might be too large or a penis that's too small. And sometimes when I talk about this, students are saying, well, how do we know what's too small? Yeah, it's kind of arbitrary. I mean, actually, a baby's penis is pretty small to begin with because they're only a baby. But sometimes it's just considered too small or a clitoris too big that might be visible, and then surgeons step in to rectify that, which can have bad consequences. Other variations include a shortened vagina, fused labia that look like a scrotum, bless you, hypospadias, which is when the urinary meatus is underneath the penis as opposed to the end. And sometimes that's considered an intersex condition and sometimes it isn't. It's really common. But sometimes it's people, physicians agree that they have a boy here, but the opening is moved. And sometimes it's a much bigger opening and it's further down at the base of the penis, and that is considered an intersex condition. Anyway, to distinguish intersex care from transgender care, basically intersex advocates have been trying to get physicians to back off, to not do these surgeries on infants, and to wait, to choose a gender, to figure out between what the baby looks like, the chromosomes, the hormone levels. Even the chromosomes aren't always what we've been led to believe, what at least I was led to believe when I was a biology major. I started out as a biology major, had to give it up after second semester organic chemistry, so I have a great admiration for you all. That just did me in. But I learned that all girls are XX and all boys are XY, and actually that is not the case. And I'm going to tell you about a case, a condition where that isn't the case. Anyway, this boy, he had what was thought at the time, an enlarged clitoris removed at birth. He was a ward of the state at the time. And so he was born with ambiguous genitals. They weren't sure boy or girl. They kind of thought girl. It was leaning towards girl in their estimation. So they removed the enlarged clitoris altogether because girls aren't supposed to have an enlarged clitoris. Well, then, as it turns out, the kid grew up. He ended up being adopted by a very, I haven't met the family, but they just seem wonderful from what I've read about them in the news. They adopted him. He felt like a boy, and he asked his mother when he was 8 years old, "When am I going to get my penis?" And, the mother had to say, "Well, I'm sorry, but here's what happened when you were a baby, and you're never going to get it." And that must have been heartbreaking. Anyway, they're suing everybody who was involved with this kid. And in fact, they came to a settlement because what they said was 20 years, if this had happened 50 years ago, that was the standard of care. But the standard of care is now evolving. There's a lot of information out there about doing these unnecessary genital surgeries. There's really no reason to have done this because this happened pretty recently. But the activists have been working for a long time to stop these early surgeries. And they're just really up against protocols that have been in place, since the 1950s and 60s, but actually the first genital surgery that I found in my research, because this is what my book is about, it was from the 1840s. So people have been doing genital surgeries, and that earliest case that I found must have been really horrible because they didn't even have anesthesia in the way that we have it now, and they surgically operated on a toddler, a little girl. They got rid of her undescended testes, and it was very controversial even at the time, and the doctors wrote about it in journals, and then other doctors wrote to complain about the surgery, and that was a great case for me to research about. But it's been happening for some time, and parents also, parents want their baby to be quote unquote normal, and they want to do everything they can to effectuate that. And if doctors are saying this is really the best thing to do, we can fix this, we can get rid of this enlarged clitoris, and that'll be the end of that. But doctors really need to listen to and researchers need to listen to what intersex people have said, which is that if you get rid of that enlarged clitoris and the baby turns out to be a boy, then you could have seen that as a penis, and now you've gotten rid of that for that kid. Or if this kid had turned out to be a girl, let's say, MC is the initials that they go by in the press. If that kid had turned out to be a girl and now there's no clitoris, Well, that's also bad because now there's no sexual sensation for that child. So kind of either way, girl or boy, that's a pretty drastic and irreparable thing to do to a child when if what you're really after is you don't want the kid to get teased at school. There's other things that can be done to eliminate teasing, like have the child change in private or something. I mean, and actually one could make the case that teasing is not even as bad as no sexual sensation, you know, when you're older. Like, and if the child can just wait to participate in that decision themselves, then that would be better. Because the thing about intersex surgeries is that usually it is not a medical emergency. In fact, there's one quote, it's further down in my notes here, so I can't flip to it easily, but a scholar of intersex, Suzanne Kessler, she said something like, intersex surgeries are done because this is a social emergency, not a medical emergency. It's been seen as a social emergency, like, oh my God, we can't tell what gender the kid is going to be. We have to do something right away to make it all cohere. But it's very rarely a medical emergency. And when it is a medical emergency, everybody agrees, intersex activists included. Yes, obviously, baby needs to go to the bathroom. So if there's something clearly wrong in that regard, you have to do whatever to make sure the child lives. So let me give you another case. So intersex, so that's kind of like the basic message to take home about intersex babies, just to wait. There's really no reason to do the surgery now, especially right after a baby's born, when the parents might be in shock, really, because we don't talk enough about this, so people don't even realize that having an intersex baby is a thing that can happen. When they get to be adults, and they're intersex adults, I'm going to give you one case of why, of why this is still important. So this is actually a copy of my book called Bodies in Doubt, An American History of Intersex, and I'm just putting this up there as a little shameless self-promotion, but also, so if you're interested in kind of how we got to where we are now, I start in the 17th century before there was any surgery, but they still had babies born with intersex traits. It's been happening. It's talked about in the Talmud. I mean, it's been around forever. Okay, wait, I don't want to talk about that yet. I'll give you another case to think about. A 35-year-old woman comes to the hospital after a fall at home. A routine medical exam and history reveals that she identifies as intersex. She mentioned this to the doctor. And an X-ray of her left hip shows that she has profound osteopenia. So I don't know if you've gotten to this yet in your studies, but basically her broken hip is basically what you would find in someone in their 70s, not someone in their 30s. So why would she have this? And I'll reveal a little bit what happened. So an ultrasound revealed that even though she's a woman, instead of ovaries and a uterus, our patient had, she told them that she had once internal testes. And further testing revealed that she had XY instead of XX chromosomes. So this is a thing called complete androgen insensitivity syndrome, CAIS. And patients with CAIS don't respond to androgens at all. And so despite their XY chromosomes, which you would think would send them along the male pathway of development, their bodies develop along a female pathway. But when this baby was born, she looked like a typical female, and her parents wouldn't have any reason to suspect that she had AIS unless some other family member had it, because it's genetic. Can be genetic. So she looked typically female, raised as a girl, going along happily, until she hits 14, 15, 16, never gets her period. So at that point, the parents took her to the physician to see, why she wasn't getting her period. They did an exam, and they found that she had internal testes and no ovaries and no uterus, so she's not going to get her period. So this was when she learned that she had an intersex trait. So there's more to her story, which they got in my case study here with a careful history. Years ago, the pediatrician had counseled her to get rid of those internal testes. They used to think, and actually sometimes still think, although I hope that this is in the process of changing, that having those internal testes could cause cancer. And so people wanted you to get rid of them, and that was standard protocol at the time. But now they realize that the cancer risk is actually kind of low, and with certain intersex trait conditions, it's lower than others. So with CAIS, it's about 1% in childhood, and slightly higher after puberty, like 5%. But since the good thing about keeping those testes, she had hers removed, but the good thing about keeping them is that the testosterone that the testes are making is transformed into estrogen, which stimulates breast development and supports bone health. So she had those testes removed, as was common protocol at the time, 15 years ago, and is supposed to take estrogen, supplemental, estrogen, to support her bone health. So she did that for a while in my little case study here. She did that for a while, but then she went to college, and she needed to go to the college health center for her estrogen. When she went there, the physician said, well, let's just take a pregnancy test first. And she said, well, I don't need to take a pregnancy test. I know I'm not pregnant, because there's no ovaries or uterus, so she knows that she's not going to be pregnant. But the physician insisted that she take a pregnancy test. And then when he found out that she had CAIS, he made some remarks that were offensive to her about the shape of her, kind of imagining. He didn't really know about intersex, and he was just kind of imagining, oh, internal testes. Well, do you have a penis too? It's some kind of derogatory remark about her genitals, which made her feel like a freak in that setting. She left his office, didn't get the estrogen, and hasn't taken any estrogen since, from college to when she's 35 and in the doctor's office. So all this is to say that I think it kind of can't be stressed enough that how physicians interact with patients, they think they're being jokey or funny or whatever. I don't even know what this, I have a lot of friends who are basically in this situation. So this is a made-up case, but I base this off my friends telling me, oh yeah, I haven't taken estrogen in 20 years. I know I should be, but I haven't. And I'm like, oh my God, you really need to go now and do this, because there's reasons to take it. Anyway, in my case here, no one told her or her parents what was really going on, and this was something else that was very common in the history of intersex, is that it's all kind of been shrouded in shame and secrecy. And so so many patients haven't been told the truth about what was going on with their bodies. In this patient's case, her parents agreed to have those testes removed because they just wanted to get rid of any trace of maleness in their daughter, because they considered their daughter, and the idea of their daughter having internal testes kind of freaked out the parents, and they never really got a full explanation either. There's always been this kind of undertone of, well, let's not tell the patient everything about what's going on, because it'll be too freaky for them. And that has negative consequences. So anyway, because ambiguous genitals at birth are obvious. Yeah, you have a question about this?
Yeah, so I think a lot of us sort of look around and turn our heads at each other, because still in class we're learning that those undescended testes do increase risk of cancer, inguinal hernias, lots of other risks, and that you're supposed to do orchiectomy before age 2.
Yeah, so that is something that's contested. I mean, I can probably send you know, I don't want to go against any of your teachers who could be here. I'm not a physician, but I know that I've heard physicians who are also intersex activists talk about this, and I know that there's some studies that are saying that these days that the cancer risk is not as high as they used to think. Yes, I mean, hernias, a lot of times people find out they have these internal testes because of a hernia, but you can also do a hernia repair and still leave them in. So this is, it's controversial, and also it probably depends on what the condition is. But I know there's a lot of, I have some intersex friends who are just really proud that they get to keep their testes, and it's like it's a thing. And you know, I wouldn't want to advise for everybody. Obviously, you have to see the patient and see the case, but I know that I have a feeling that there's more and more research is going to show that these are protocols that used to happen in the past and might be changing, especially because there's ways now to monitor, you know, what those internal testes are doing in ways that they didn't have, you know, probably 25 years ago, ultrasounds and whatever else. I don't even know the ways, but other ways to monitor. I mean, breast cancer is also a risk for women, and we don't get rid of women's breasts. So, you know, that's just kind of something to think about, like why we're so eager to get rid of these testes. And I think that part of that eagerness is because we kind of really want to say, girls are girls, here's the body parts that they have. Boys are boys, here's the body parts that they have. And that insistence on the gender binary, I think, has colored a lot of intersex care, probably even, obviously even today. There's another thing that people do, and then I'm going to end this in 2 seconds so you can ask more questions. But another thing that people do that I don't know if they still do this today, I would hope not, but one thing is some intersex conditions for girls leave you with, part of the condition is that you have a shortened vagina. And so what they have done in the past is to create a deeper vaginal opening. Now, this is like a perfect example of a social surgery and not a medically justified surgery, because the only reason that you would need a deeper vagina is for later on heterosexual penetration. And that may or may not be the person's, what they want in their sex life. There's one woman who said in the 1970s that her doctor told her, you needed this surgery. She was 13. So they didn't do it in toddlerhood, which is also common, but they did it at 13. They said, you need this to increase the depth of your vagina, quote, if you ever want to have normal sex with your husband. Well, she turned out to be a lesbian, so she didn't really care about that. And her parents kind of made her do this because she was only 13. But if she had been given all the options, if someone had really said, what do you think about this? Let's get your opinion. Then she might not have had to do this. And for a toddler especially, there's really no reason why a toddler would need this. And parents have talked about how horrible it is to keep that vaginal opening with dilators, which is what you need to do for a year, several times a day, a year or more, to make sure that that vaginal opening doesn't just close. So if you can imagine how horrible that must be for the parents to have to insert a dilator in a screaming 2-year-old, all for the preservation of what a normal girl is supposed to look like, it's horrible. And it's really a violation of bodily autonomy. And there's no reason why we just can't wait until that child is older and then have surgery if they want to and not have it if they don't want to. So just to conclude, and then I'll answer a few questions, I think that the needs of intersex patients really need to become a more integral part of medical school curricula. It's about intersex, and the incidence of intersex is about 1.7% of the population. It's not as rare as we always have thought it was. Intersex patients need to be treated with care and sensitivity. And both groups, both trans and intersex, to bring it back to trans, deserve autonomy over medical decisions that concern their bodies. And I think I'll just leave it at that and have a couple of minutes for questions. Thank you.
Thank you, Dr. Rizal. Thank you, Dr. Rice.
Reis.
I really enjoyed your talk, and I'm very grateful that you gave it.
Thank you.
My question is about really, along for, I think, specifically to do with individuals who are born intersex. And I know that resection surgeries are lesion, but I also know from my experience on an ethics committee at a children's hospital that now there are nascent techniques whereby you can tuck in the penile tissue, and then by default the child would grow up as a girl, and then you can untuck the penis, the penile tissue, should the child decide to live their life as a man. And I just wanted to get your opinion on that. And then secondly,
Wait, so let me just get this right. So they do this after the child is born or in utero? Because that's going to be another...
After the child is born. So truly ambiguous genitalia, where you can't really make a demarcation one way or another. And then secondly, how do you convince parents that sexual identity isn't really a choice that a parent can make for a child, but is somehow doesn't quite fall under the purview of a decision that a parent can make for a child?
Yeah. I mean, that's the question about the penile tissue. I hope the person's okay out there. So I hear somebody crying up there. I'd want to know more about that. I don't know. I honestly don't know. I guess I would say, just off the bat, without really knowing what that procedure is, I guess I would say just leave them alone and let them live their life with whatever body that comes out. That would be my go-to answer. But your other question is a really important one. How to convince parents to just not do anything. And that doesn't mean, and I just want to kind of correct this for the record, or just emphasize this for the record, it doesn't mean that you need to raise your baby with a gender identity of intersex. You can choose boy or girl. I agree, in today's world, how could you possibly say, okay, the girls are going to line up over here, the boys are going to line up over here at school, and this kid who identifies as intersex, you come with the teacher or whatever. Like, that would be so horrible for the kid. So intersex activists agree you should identify a gender that you think is the most likely, but then be honest with the parents that we hope this is going to be the gender that your kid turns out to be, because that's going to be the easiest for them. But it is possible that your child will feel differently, and we honestly don't know. And I feel like having that sense of humility on the part of providers, it's not a bad thing. It's a good thing, I think. And I think that as this needs to be also written up in like those books, What to Expect When You're Expecting, that this is a possibility for parents. They should be learning about this at childbirth classes. I didn't learn about this when I had my kids, but I wish I had. And so that's something that the more we talk about this, and that the more that parents don't feel like they are the only ones that had an intersex child, and I think a lot of parents feel very isolated and alone with this when it's not necessary. There's so many people they can be connected to, and intersex people have written a lot about this. Like, there's a whole issue in the Journal of Narrative Bioethics that talks that if I was counseling a parent who had an intersex kid, I would say, why don't you read what these other people have written about their care and what has worked and what hasn't worked, and connected them to people. But that's like a major culture change, what you're suggesting. And I think we'll get there. I do, because look at this. You're having a whole hour devoted to the ethical care of trans and intersex patients. This is inconceivable 20 years ago. So I think that we will definitely get there, but changing culture is not that easy. So thank you for that question. Yeah.
Hi, how's everybody doing? So there couldn't be a gathering without me saying something, right? Thank you very much. This was amazing. I wanted to give you guys some personal experience with this. In my last 20 plus years of practicing, I've had to deal with this a number of times. In my particular practice, it was for congenital adrenal hyperplasia. And oftentimes you'll see ambiguous genitalia. And I can't emphasize enough how much in a child the issue has to do with perceptions by the parents. And they influenced, I can tell you, 20 years ago in a much different way than in the last 5 years. So there has been progress, and I can tell you that just from my own practice and experiences. But the reality is this is a huge issue that oftentimes is not talked about. And these types of talks, these types of materials, books, research that's coming out, it's your obligation, if you're going to be a patient advocate, that you read this material, you understand where the complexities are, and treating the whole patient means their families, their caregivers, and the people that are influencing their decisions. So I just wanted to make a comment. Thank you so much for everything that you've said.
Thank you for that comment. And thank you all for coming here, and good luck with the rest of your semester and year and lives.
But before we end, I have one question too.
Okay.
You and I met with about, 20-some people last night at KC Care Clinic, an event that was organized by one of our board members, Sherry Wood, who is CEO of KC Care. And some of the people who were there really specialize in transgender care, transgender clinics. Should that be necessary to have specialized transgender, intersex providers, or is this something that you believe ought to be, that anyone who is a physician ought to be able to respond to
Right.
well?
That's a good question. I mean, I think that for primary care physicians ought to be able to see anybody. You can't really say, well, I'm not an expert in diabetes, so I don't know what to do with you. And the same thing with intersex or trans. You ought to have a passing familiarity, or more than a passing familiarity, kind of a basic familiarity with any of these issues, I believe. But then I do think that there is a role also for transgender care, because it's a specialty like and intersex care too, and it would be a specialty like an endocrinologist is a specialty, or a cardiologist is a specialty, and they really know all the ins and outs and the research of that particular thing. But now, because there's so much transphobia and so much ignorance, that when a trans person just goes in for routine whatever, unless they go to a trans-friendly provider, they very well may face this kind of hostility. And so if I were trans and I was going for a broken leg, I'd want to go to a trans clinic, because at least I know that I'm going to be seen and dealt with respect. So I guess I would say you probably are going to need both in the future as well. One for the specialty of maybe gender reassignment surgery and the hormones and everything, and then one for just when you have a cold, you can just go to your primary care provider and the person's going to treat you with respect.
Thank you, and please join me in thanking Dr. Reis.